for very successful health systems is when you have a very robust primary care system, the dependency on emergency services becomes less. Norway is one of these, ranks very, very high in terms of their metrics on their healthcare system. And one of the reasons, not the only reason, but one of the reasons is because they have a very robust primary healthcare system. Ours needs a bit of support, and that's our current landscape. I guess I've been in paramedicine since the late 90s and worked in a variety of different services, including spending some time in the US. And had been in the college sector for many, many years, working with Centennial College. And now I work with York Region Paramedic Services and been a paramedic there for a long time, an advanced care paramedic there, but now take on more of a research and development role there. And then in my primary roles with the University of Toronto with the Department of Health and Society, and also supervising the paramedicine program there. And so, but in between all of that, there's been lots of different roles and projects, working with the base hospital system, working with the national organizations like the Paramedic Association of Canada, the Paramedic Chiefs of Canada, and also had the chance to travel a little bit internationally to look at different systems. Part of a Liverpool, for example, we had a paramedicine student exchange program with Liverpool, so spent a number of years there. And so all of these things have been, shaping the way I look at paramedicine these days.
Out of curiosity, what's your favorite? Out of all that, what's your favorite?
Well, I would say the education. I really enjoy being in front of students, and if the research, career doesn't work out, or whatever it might be, or I can't work with paramedic services forever, then I hope to be with learners and students forever. So that's it's and of all types, like not just paramedicine students. In the Department of Health and Society, I get to work with a number of students working in multiple different kinds of majors, and so I get to teach health policy there and health systems and things like that. And so I enjoy all of that.
I think what's so cool about everything you just said there is, you're looking at a project that you've built. Do you think that it would be possible without the diverse experience that you've had?
No, I don't think so. But I also think that it takes a lot of bravery on the part of the people I work with to do the things that I do. So, the two of you will know also, even with, going back a bit, and some people listening might be aware of the global rating scale, project. And at that time, that was a major shift. And it took people willing to listen and, consider it and open their idea or open their mind to the idea. And it's the same thing now with these health system projects. It takes a lot of bravery and willingness from a lot of different people. So that's what I'm most thankful for.
Because we always laugh at this. Before the global rating scale, you would do an amazing scenario, and if you didn't aspirate when you did an injection, it would be a critical error. And look how far we've gone with your amazing research. So we really want to commend you for doing that. And just the fact that you created the IMPACC program is the next monumental change for the whole healthcare system. Do you mind giving us a brief overview of what the IMPACC program is?
Yeah, I appreciate the comments there. Again, lots of people involved in all of that stuff, but yeah, I appreciate that. So IMPACC is yes, a relatively new, but we've been working on this probably from about 2016 or so, and 2015, 2016. And it started with a study that looked at that time, Ontario was dealing with a crisis with the emergency departments. And where we were feeling it as a paramedicine community was in long offload delays and long wait times and things like that. And so there was this crisis going on. And so we were looking, and that was definitely the focus at the time. And we were looking at whether or not there was more paramedicine could do, and this is going back to 2015, 2016, the climate was very different then. Anyways, that study we followed 3,000 patients that we picked up from the 911 system, transported them to the hospital, and then followed their clinical course. and all the way to either admission or discharge. And what we found in that small study was that there was 65% of the patients that paramedics were transporting don't require admission. And when they get there, some of them get nothing. Some of them get a host of diagnostics. Some of them get a diagnostic and an intervention. And so we looked at all of that. And the majority of patients, I would say, are usually of that 65% are getting a diagnostic of some kind and then, reassured and then sent back on their way and discharged directly from Emerge. And when we looked at the kinds of diagnostics and interventions they were receiving, we were realizing that some of this stuff could be done in a pre-hospital setting. And some things, of course, not. Like, for example, if they were getting an X-ray or an MRI, even though we did look at X-rays in paramedicine, but if they were getting some sort of big technology like that is not available in the community, then, of course, they need a hospital. But in a lot of other instances, they were receiving diagnostics only, for example, and we thought that's something that paramedicine could do for sure. The other thing that we learned in that study was that the paramedicine who were transporting those patients who were not admitted were only providing services, 5 to 10% of the time. And that to me was shocking. It shouldn't have been shocking, but it was a bit shocking. That number was as low as it was. And, so that study was done. It opened our eyes. We started to look at these things. Fast forward to a subsequent study, and we found again, now this is years later, this is just recently, actually, we just submitted this paper for publication. The healthcare context is very different. I can come back to that in just a moment, but just to show that line of thinking, we looked at this time 6 different services across 7 years of data, which is about 1.2 or 1.3 million records. And what we found in that data was a very similar story, that the services that paramedics are providing to the public are somewhere around the 20% range on average over that 6 years. Again, really low when you look at the way the model has been built. It's been built for a particular patient demographic, a patient type. It's been built and viewed from a lens that aligns with that strategy. And it serves that demographic really, really well. But the broadening use of paramedicine by the public and the increasing use of paramedicine by the public is suggesting that there's more and more of a misalignment. So all of these things were, in addition to some of the healthcare landscape issues that we can talk about if you'd like, were, creating the impetus for IMPACC, essentially.
So what are the guiding principles to it all?
Right. So IMPACC, I would, also say that it really is just a concept. It isn't a thing in itself. And the concept can be, applied in lots of different ways. But the principles for it, and actually, if I can go back one more step, is I want to be clear that we're talking about, core paramedicine. And by that, I mean the 911 system. There's lots of variations of paramedicine in Ontario and in Canada and worldwide. But again, I'm talking specifically about the 911 system. When someone calls 911 for an emergency or for something that they believe is an emergency, and we respond, this is where IMPACC lives. And so, to answer your question now, in terms of the principles, the number one principle guiding it is really this issue of alignment. But the other is, and I'll talk about that in just a sec, but the other is this idea of attending to the changing healthcare landscape or keeping up with the healthcare landscape. And so when we look at, and I guess timeliness would be another, timely access to care is another major principle. But if I go to the alignment one, I would say that all we're trying to do is create a paramedic system that is better aligned with the needs of the public, and that those needs are identified by the public, not us. In other words, they will contact us when and where they want, how they want, and for whatever reason they want. And we can, try to educate the public on when to use paramedic services, but in reality, that strategy never works. And so they continue to use it in the way that they see fit. And so our job under IMPACC is to try to create that alignment, is to try to, so that when we get there, we are providing more for them based on their needs at the time. So that would be the major core driving principle for sure. The second is around the changing healthcare landscape. So as I said, in 2016, the issue at the time was really ED pressures. Like we were really seeing a lot of discussion about EDs and how to support strategies related to EDs, and that continues. But what also has happened is that we see advances in the healthcare system, and we see, again, changes in different priorities. I'll just give you two that we talk about in the paper related to this. Is one around integrated care, the other one is around primary care. And on integrated care, that's advanced quite a bit. And so there's a lot of literature outside of paramedicine that talks about the value of integrated care, it being more cost efficient, it being more patient centered, it being ways of creating efficiencies and optimizing care and so on. And lots of challenges with it too. But the point is, there's a lot of hope and belief that integrated care and evidence that integrated care really is the way forward. The second is around the primary care crisis that we have in the country, where not everybody has a family doctor or can access healthcare. And so when that happens, they use emergency departments and emergency services more. Or more importantly, they get sicker because they don't have access to primary care. And so that can translate into crisis and emergencies. And so we had these two, and there's tons of work going on outside of paramedicine on both of those topics and many others, but just talking about those two as an example. And when we looked at paramedicine, and again, I mean core paramedicine, we see that there's just, we don't see those two things showing up in core paramedicine systems. And so IMPACC was, again, an effort to try to align with that changing healthcare landscape. And it is intended to be situational, contextual. In other words, it's responding to what's happening in that particular community and environment.
So from a patient focus, traditional paramedics in our current model, if they have a complaint that's social or more chronic management, and frontline paramedics at this time can't really do much about that, how would IMPACC actually integrate this care from a holistic lens?
Yeah, so the two of you will know that when people go to these 911 calls, they're equipped to deal with emergencies, and the guiding paradigm driving the development and design of paramedicine, including education, has really been driven by that for many years. And so they go and they are there to serve emergencies, and they do that exceptionally well. And I should mention that the alignment, when we looked at the alignment of that, that's very high, like say 60, 70%, somewhere in that range. And so the system is very well designed for that. The issue is that the design, we don't go to a lot of those types of events, in comparison. Those are less than 5% of the time for CTES 1. And then when you look at CTES 3, 4s, and 5s, and that occupies the bulk of what we do. And so to answer your question about these social issues and other issues that patients might be experiencing, we just haven't equipped paramedics to do that well enough. And so sometimes they don't see it, they don't attend to it. I would say they do more now than they ever have, but still not as good as they could. And so one of the things that we've highlighted, again, in a number of different projects, there was a project we talked about roles for paramedics, another one that we talked about the principles to guide the future of paramedicine. In both of those projects, we talked about health and social care, a health and social continuum. And we were trying to introduce this idea of saying, look, every single patient we see has both a health and social issue. They vary on degree. Sometimes it's a very, the only thing that matters in the moment might be their health issue, but even that is contextualized. And other times it's mostly a social issue with some sort of medical issue happening at the same, or health issue happening at the same time. And that continuum is not something that we were seeing, we were attending to well enough. So you'd find patients who were having their health needs looked after, and sometimes not enough, because we would, again, that 5 to 20% range of alignment. But their social issues were never accounted for, both in the decision to transport, in the decision to treat, in the decision around continuity of care planning, coordinate, any of that, just not sufficiently attended to. And so we wanted to put a real focus on that as well, to get people thinking differently. And it is a shift for paramedics these days to see that as, I think they recognize it's valuable, but the transition, their focus has been a bit of a challenge, but they're certainly doing it. And we have some early evidence that's suggesting those who have been IMPACC trained are starting to attend to those issues and integrate those issues into their care plans.
And I think it kind of probably touches back on your previous experience, because I think when you look at the ministry's change for patient care models and you look at general sentiment across Ontario, I imagine you hear more of the, well, how do we manage a population who perhaps is calling 911 what we see as in an inappropriate way? So, we're not accessing the 911 system the way it's supposed to be. Probably goes back to a lot of our education that we're managing true emergencies, which I've always found interesting from the education lens, because we all know that's not the case. That 20 to 25% is obvious to everyone. And I think it's easier sometimes to take the lens of, well, why is this person calling? And not considering the breadth and depth of access and alignment that is missing for them to get what they need. So I think it's such a cool process to kind of flip that on the head and say, true emergencies are the only goal of 911. No, let's look at what 911 is actually used for across the span of its existence. And if that's the true practice, then we need to align to that, not align the public to what we think is the necessity. So I guess I have two questions. One is, how do you get to that? So I think that it does take some abstract thinking and probably critical thinking to get to that as the philosophy, rather than saying, let's just focus on decreasing 911 calls. Let's not take as many people to the hospital as possible, which I think is some of the goals of a change in the modeling system, and actually focus on real needs of people and changing them. And then, have you noticed any change in, I think role misalignment is huge in paramedics, where I think I'm going to do one thing and then I'm doing another. Are you seeing that change in your impact medics, where now they're going, okay, this is the holistic job that I signed up for, rather than just dealing with that very small percent of emergencies?
Mm-hmm. It's a great question. So let me tackle the last one first, around paramedics and their identity and the dissonance that they have, that learners have when they come out of the education system. They go into the job and they find some dissonance, right? They've been prepared quite a bit for the emergency side, and we have to continue to do that. At no point am I suggesting that go away. But they do have some dissonance. Like, get there and they're just like, oh, this isn't what I thought it was going to be. That identity is very, very, very strong. It is signaled in so many different ways. And I am guilty of this myself, of creating cases and creating OSCEs and creating all these signals that suggest that that's all that matters, and almost silencing some of the other things that seem to matter, like, again, these kinds of social issues. And so when we started to transition this, we started to get paramedics to think differently. We've gone through we're in 3 different cohorts of paramedics that we're doing this with, very experienced paramedics whose identities has been long established, very securely established. When we get them to think differently, it is a shift. And to be honest, I think it's something that I underestimated in how difficult that would be to transition. But to their credit, they are indeed transitioning. Some quicker than others, but the point is they do get there and they see it. And like you said, it's just something that they know to be true when interacting with patients, that these patients might need something else, something different. And so they see that, they know that, and sometimes they feel empowered through this concept. Other times they feel like their identity is being threatened. It's not what they wanted. It's not what they signed up for. They're here for, the emergencies, that kind of thing. So we're dealing with all of those things as we transition into this model of care. But again, it's their willingness and their open-mindedness towards this that is causing the any success that we might be having with it. The other part of your question was about, getting people to see this. And so both at a system level and an individual level. And here I would describe it as paradigms. Like, paradigms, as I think of them, are ways of seeing the world. And when you have a particular lens on which to see the world and see system design and paramedicine, et cetera, you see certain things and you don't see others when you put on, certain glasses, let's say. And so all we're trying to promote is, an augmented paradigm. Like, don't lose the emergency focus, but augment that with another paradigm that lets you see, all these other issues that are in front of you. And I don't mean just for paramedics, but I also mean for systems, for system leaders, for system designers, for base hospitals, for chiefs, and so on. for them to see the system in a slightly different way. And once you pick up this paradigm, you can't help but see it in a particular way, you know? And so you start to make decisions that are aligned with that particular paradigm. And in our case, the paradigm that we try to push forward is this interprofessional primary care, health and social continuum kind of lens. And with that then comes so much information, because you become open to it immediately and you start to see things differently and you start to wonder why we do things a certain way. And so once you introduce that paradigm, again, the education programs change, how we certify people changes, how we prepare them for employment, our continuing professional development strategies are changing. The medical directors we want to see are changing. Our relationship with the base hospital is changing. Like, it all starts to shift just a little bit. And that's that incremental growth that we're trying to achieve. So I think it's both those dealing with the paradigms and also dealing with the identity is unavoidable, I think. And one thing I'll mention here too is there's a researcher, his name is Michael Corman, and I'm not going to do justice to his work, but he's an ethnographer and is interested in paramedicine education and paramedicine in general. And he is, getting us to think differently too. He's suggesting, like, look, new paradigms are needed, and that we've been focused too much on the biomedical model, and that we have to broaden that lens to consider others. And he proposes a number of different ideas of ways to look at it that include, moving away a little bit from, or at least augmenting the biomedical model. So it's the same idea. I think he and I agree that there just needs to be this, this paradigm shifting and or augmenting that paramedicine needs at this moment.